I'm Christine Leeper, Assistant Professor of Surgery at the University of Pittsburgh Medical Center. Thank you to the American College of Surgeons for the opportunity to discuss the use of whole blood in pediatric patients. I have no relevant disclosures to report. Both in the United States and worldwide, injury is a disease with a tremendous and lasting impact. Trauma is a public health epidemic for children and young adults. It is the leading cause of death, accounting for greater than 75% of total annual mortality, and a source of substantial long-term morbidity and financial cost. Hemorrhagic shock is the most common cause of preventable death in trauma. That's across children and adults, military and civilian settings. In injured children, there's a complex relationship between shock, the iatrogenic causes of coagulopathy, and what is designated as trauma-induced coagulopathy, a term that encompasses the body's complex endogenous response to injury via the hemostatic and inflammatory systems. Trauma-induced coagulopathy is frequently seen in injured children and associated with multiple poor outcomes. While mortality as an outcome in pediatric trauma overall is low, death amongst children with coagulopathy and life-threatening hemorrhage can reach rates above 50%. Early recognition of shock and interventions to address it are therefore necessary in order to improve outcomes after injury. This may include surgical bleeding control as well as aggressive hemostatic resuscitation. The desire to improve pediatric hemostatic resuscitation such that it is more effective and efficient has led to renewed interest in the use of whole blood for pediatric trauma patients in the United States. The availability of cold stored low titer group O whole blood, hereafter LTOWB, in adult trauma centers is known to be increasing. Its use in pediatric patients has been described, though it remains less common. In an effort to better understand the practice pattern in the United States, a survey was recently distributed to pediatric level 1 trauma centers. Of the responding institutions, 10 pediatric level 1 centers had a whole blood program that was active or about to start. Of the centers who did not have a whole blood program, most stated they were interested in and were discussing the possibility of developing a whole blood program. The number of institutions with whole blood programs is increasing rapidly in recent years, with almost half being initiated in 2021. The survey provided valuable information regarding some of the perceived and actual barriers to implementation, which included too few bleeding patients, as well as concerns about inventory management, waste, cost, patient safety, and efficacy. These are valid and real concerns when considering initiation of a pediatric whole blood program. Some of these, such as patient volume, are not modifiable, but several can be addressed with pediatric specific data. So let's look at some of the existing pediatric trauma data, as well as directions for future research. These are data from the early experience with whole blood in injured civilian children from a single pediatric academic institution. This first cohort of 18 severely injured children were transfused whole blood in the trauma bay as the initial resuscitative fluid. This was a small cohort study with the outcomes of feasibility and acceptability. Indeed, the development of a whole blood program, as well as the practice and logistics of transfusing whole blood, were feasible and acceptable to clinicians. Additionally, this panel on the right is a time to event analysis, comparing the number of minutes to transfusion of whole blood versus number of minutes to transfusion of red blood cells, plasma, and platelets in a historical cohort. As expected, the transfusion of whole blood was substantially faster, supporting the ease and efficiency of administering a single whole blood unit compared to multiple component products. This being a relatively novel therapy in children, safety precautions are of the utmost importance. The whole blood in use at our institution and at others is a highly select specialized product. It comes exclusively from male donors in order to decrease the risk of trolley. It has low titer anti-A and anti-B antibodies. We initially had restrictions in place, which have since been eliminated or eased as the safety data are now more robust. So first there was a weight restriction. Age has since been expanded from greater than 3 to greater than 2 and now greater than 1 years of age. And these were both in place to ensure that surface antigen expression was sufficiently mature and circulating blood volume was large enough to absorb minor incompatible antibodies. Further, the use was initially for trauma patients only, and this has since been expanded to any child with major bleeding. Lastly, at our shop, whole blood is RHD negative, so both male and female children are eligible recipients, and there is no risk of Rh alloimmunization or antibody development, making further cross-match difficult. Of note, the risk-benefit balance of Rhd-positive transfusion to female children whose Rhd type is not known is beyond the scope of my talk today, but is certainly worth exploring to increase the availability of whole blood for children. We have a rigorous monitoring protocol in place, which includes hemolysis markers for all recipients of whole blood at time of transfusion and on post-trauma days 1 and 2. We also monitor for major transfusion reactions, which are reported to the blood bank and subsequently reviewed by our transfusion committee, as for all blood product reactions. In this analysis of 47 children with hemolysis markers sent on trauma day 0, 1, and 2, there was no difference in any lab value. Bilirubin, haptoglobin, LDH, reticulocyte count, potassium, or creatinine between Group O and non-Group O recipients at any time point. Further, there were no major transfusion reactions reported. Again, looking at adverse events, these data are from a propensity matched analysis comparing pediatric recipients of 1 unit of red blood cells who form the component therapy group, or 1 unit of whole blood plus or minus additional components within the first 24 hours of admission. The outcomes of interest included thromboembolism, acute kidney injury, sepsis, and organ failure based on the pediatric logistic organ dysfunction, or PLOD2 scores. Seen here is a table of PLOD2 scores on post-trauma days 3 or 7. There were no significant differences at either time point, nor were there any differences in any of the in-hospital complications. So after evaluating feasibility and safety, next on to outcomes. This is a propensity analysis of 28 whole blood recipients matched to 28 component recipients on age, mechanism of injury, severe TBI, age-adjusted admission hypotension, and need for urgent surgery. The main outcomes included serial base deficit and international normalized ratio, or INR values, and blood product transfusion volumes. So you can see here that time to resolution of shock based on the base deficit was faster in the whole blood cohort as compared to the component therapy cohort. The whole blood cohort had lower post-transfusion INR compared to the component therapy cohort. INR, while not a consistent indicator of clinical coagulopathy, does seem to reflect global hemostatic dysregulation and therefore is a valuable biomarker and prognostic indicator. And regarding transfusion volumes, the whole blood group received less weight-adjusted volume of red blood cells, plasma, and platelets as compared to the component group. This, in theory, could translate to fewer donor exposures and/or less cost, although that remains to be studied. This group reported a larger cohort of patients, ages 1 through 17, from the Trauma Quality Improvement Program, or TQIP database. The authors compared recipients of whole blood plus components to recipients of components alone. A propensity match was performed, controlling for demographics, mechanism of injury, ED vital signs, injury characteristics, interventions for bleeding control, and trauma center verification level. The primary outcome of interest was volume transfused. And in this cohort too, there was no difference. The patients in the component therapy group received higher volumes of total product, red blood cells, plasma, and platelets within 4 hours and 24 hours of admission as compared to the whole blood group. Whole blood recipients did have fewer days on the ventilator, though no reduction in overall length of stay. So now to address the elephant in the room. In none of these studies, looking at all comers, recipients of whole blood, was there any significant difference in in-hospital mortality? There was no difference in functional disability based on discharge to a rehab facility, and no difference in in-hospital length of stay. So why might that be? There are 4 potential responses listed here, probably more than one of which is true. First, more data is needed. These are a handful of pediatric whole blood studies with relatively few subjects, and larger cohorts are needed to have adequate power for a low frequency outcome such as mortality. Second, perhaps we're not using the appropriate outcome, and instead of overall or 28-day survival, we ought to be looking at early mortality, death due to bleeding, and use of hospital resources. Third, the modest amounts of whole blood transfused in these studies may not be enough to increase survival. Perhaps there's a dose effect where the benefit to the patient may increase as the amount of product transfused increases. And lastly, these studies reflect a diverse trauma cohort, and there may be subgroups of injured children who are more likely than others to benefit. The next steps for research include addressing some of these hypotheses. So shown here is some preliminary data from work in progress, looking at a subgroup of massively transfused children. And on a survival analysis, you can see that whole blood in the dashed line is associated with a survival advantage as compared to component products at certain time points. So this and additional studies will help to further the discussion regarding the efficacy of whole blood in children. Note regarding the use of whole blood in pediatric cohorts outside of the trauma population. There are other applications, though the product in use is more commonly fresh, warm whole blood versus cold stored LTOWB. However, LTOWB is in use at select centers for diverse etiologies of bleeding, including medical and surgical bleeding. However, there's very little in the way of data published regarding safety or outcomes, so additional research in this area is needed as well. In summary, pediatric trauma whole blood programs in the US are increasing in number. There may be some advantages to whole blood transfusion as compared to component therapy, but more studies are needed to support or refute these data. Specifically, large multi-center trials should be pursued. I'd like to acknowledge the tremendous multidisciplinary team at the UPMC Children's Hospital of Pittsburgh, as well as our collaborators across the country. And thank you once again to the college for the opportunity to present today.